evening, everyone. My name is Deborah Cora, and I'm a nurse practitioner and Senior Director of Operations for Pauley Heart Center. I'm delighted to welcome you this month's session at our Cardiovascular Medicine for Primary Care Providers, CME series. If this is your first time joining us, this series takes place the third Wednesday of every month throughout 2025, and we are excited that you guys are here. Before we would begin, I want to do a quick reminder that to claim the CME credit, please text the code 34444 to 804-625-4041 within the next 48 hours. And make sure that you complete your course evaluation within the next 30 days to receive your credit. If you need help with the Cloud CME, you can visit the vcu.cloud-cme.com, or you can email me. My email is easy. It's deborah.cora@vcuhealth.org. And I'll go ahead and drop that information in the chat for you guys to see. Now, I'm thrilled to introduce tonight's speaker, Emily Holt. She's a family nurse practitioner. Emily has worked within the VCU for the last 4 years and is a dedicated member to our electrophysiology team. She's known not only for her depth of knowledge and clinical expertise in arrhythmias, but she's also known for her approachable and compassionate style, which makes her a favorite among patients and colleagues alike. Whether she's helping guide treatments or mentoring others, Emily is consistently the go-to resource in our EP world here at VCU. Her talk tonight is titled "Don't Miss a Beat, a review of palpitations and tachycardia." It's a topic that's highly relevant for both primary care and cardiology, and I know that she'll walk her way through this valuable insight. We're incredibly grateful to have you with us, Emily. Please join me in welcoming Emily Holt.
Well, I am very grateful to be here this evening. Thank you guys for taking your time to take a listen into this talk on something that is incredibly common, that I'm sure you see in your practice or will see in your practice, and that is the topic of palpitations. It's a very common presenting symptom, and I'm going to go over things as far as the objectives with this talk. Common arrhythmias that may associate with palpitations, how to identify those on EKG. I'll have a couple examples. And I'm going to cover, some ways to treat, manage, and definitely we'll touch on reasons to refer to us in the EP world. All right, let's go to my next slide. Okay, there we go. All right. Disclosure statement, I have none. Right. And I already touched on the objectives. Okay, so starting with you have a patient presents to your clinic. They're telling you, hey, I've been feeling, and they may not call them palpitations, but they may say, I'm feeling some weird beats, skip beats, pauses. And so you start to dive into what's going on. A really great tool, especially if a patient's presenting with palpitations, tachycardia, is to get an EKG. That's going to tell you so much right there. So that's why I really did put it as step one, as far as, when you're screening, working these patients up. Next step, of course, is diving into a detailed history and physical. History would be focusing on some, crucial questions that might be able to help you identify what's going on. And then, of course, a physical exam. And that would really focus on feeling that pulse. Is it regular? Is it irregular? Taking a listen with your stethoscope. Are you hearing an irregularity with your auscultation? Are you hearing, beats and then a pause? So that can give you some insight that something's going on with the rhythm. Here are some detailed questions that I highlight kind of when I'm going through my history or HPI, if when a patient's presenting with palpitations, I do like to ask questions such as, did they have, was it the onset, was it abrupt? Was it a quick termination, a quick onset, quick offset is a common question I ask. Um, if it does have this abrupt onset and termination, I typically think this might align with an SVT. Also, I think SVT, if they've had these palpitations in their childhood or teenage years or early adulthood. Older adults, I would, if they're feeling some palpitations or presenting with tachycardia, certainly start to think about AFib, a flutter. If a patient's telling you they feel instant or they feel like a skip beat or they feel like a pause, definitely would think about PVCs or PACs as one of your differentials. Rhythms that are rapid and irregular typically suggest a proximal AFib, flutter, or ATAC. Rhythms that are rapid and regular may suggest like a SVT or a VT. Um, and any patient that's presenting to your clinic and they said, yeah, I got really lightheaded, I almost passed out, or I passed out, and then associated with palpitations or tachycardia, definitely would prompt a good workup. And of course, that to involve, a heart monitor, an echocardiogram, lab testing, and we'll get more into that as we move on. So first topic I'm going to talk about are PACs or premature atrial contractions. I put an example here. If you can see kind of right here, you've got these normal sinus beats, and then you get to have this beat that follows immediately after the T wave here, and it's early, it's premature, and then you have this slight little pause after, and then you resume back into normal sinus beats. So this is a classic PAC right here. I'll give another example right here. So PACs, what are these? It's a premature activation of the atria from a site other than the sinus node. They occur in both young and older adults. You may be able to detect them with several minutes of listening to their heart. Typically, patients describe these as a skip beat followed by a pause. That's a very classic description of these. Some patients may say, hey, when I lay on my left side, I feel them more or they feel worse. And this is true. And the reasoning for that is because the heart gets closer to the chest wall. So any ectopic beats that they may be feeling, they will feel them stronger if they're on their left side. These can be identified on surface EKG. They also can be captured on cardiac event monitoring, such as a Holter or MCOT. Really, so now I'm going to kind of dive in to what to do about these. We all can have these, and if certainly they're asymptomatic, I would just provide reassurance to the patient that these are benign. If they are feeling them and they're quite symptomatic, definitely screen your patient, make sure they're not having any precipitants. This could be smoking, alcohol, a high stress level, caffeine, any stimulants or stimulant medication can sometimes bring these on. So I would screen that. You also could screen, look at electrolytes, thyroid. Sometimes those can precipitate as well. For patients that, aren't on it, can't identify any precipitants, they continue to have these persistent symptomatic PACs, then you could consider medical therapy. Beta blockers or calcium channel blockers have a really good success on suppressing and sometimes eliminating. So, if you have any, a really symptomatic patient with PACs, definitely can refer them on. I did put this one little note in there about if you see a high burden or high amount of PACs. Now, burden of PACs are usually best captured on Holter monitoring. And I usually, especially if I'm trying to work up PACs, PVCs, and trying to get an accurate amount or burden, I usually start with at least a week, but I typically order a 2-week monitor to really get a good burden assessment. But talking about PAC burden, if you're seeing it in like that 20 to 30% range, I'm just making a note to keep a close monitor for any atrial arrhythmias, such as AFib, as a high PAC burden can be a precursor for that. All right, so that moves us on to PVCs. So these are premature ventricular contractions. They're early extra heartbeats coming from the ventricles. A very common presenting symptom with PVCs are palpitations. Um, PVCs, they can be they're a little trickier than PACs. PVCs can be unifocal, meaning coming from one site. They can be multifocal, coming from multiple sites. And that really depends on kind of the area, the morphology, the origin within the heart or the ventricles. Common cardiac causes of PVCs typically would be hypertension with like a elevate or a LVH, left ventricular hypertrophy, and prior MI or even acute MI. You could certainly see a lot of more ectopy, heart failure, hypertrophic cardiomyopathy, congenital heart disease. So definitely, if you're seeing PVCs or frequent PVCs, I would definitely start with an echocardiogram that can screen for any structural abnormalities in the heart. Non-cardiac causes for PVCs, COPD, sleep apnea, pulmonary hypertension, thyroid issues, that being an overactive or underactive thyroid, stimulant use, nicotine, alcohol, drug use those can be precipitants for PVCs. So when you're seeing a patient in your clinic, and they're telling you they have palpitations, you get a surface EKG, you're seeing some PVCs. And in the next couple of slides, I'll show you a couple examples of those PVCs or common PVCs we see. But I would screen your patient, ask your patient about, social history, any alcohol use, caffeine, drug use. Definitely, I would check labs with electrolytes, magnesium, potassium, check their thyroid, make sure all those levels look okay. Another question I do ask patients, do they relate to exercise? Do they not? If they do feel that palpitations increase with exercise, then you can always, a next step could be an exercise stress test to see if there's any arrhythmias with stress, see if any PVCs increase with stress. And of course, if you're going down that avenue, you can certainly refer and we can work that up. So the next part, of course, is the burden. Again, as I mentioned before with the PVCs, PVC burden is really important. That gives us kind of something to work off as far as the percentage of PVC burden. So I will highlight, we definitely consider a significance if the PVC burden is 10% or greater. And because a condition you can develop is something called a PVC-induced cardiomyopathy. So we do encourage, in my practice, I typically order a 2-day Holter or MCOT. I think when you go in to order, if you do order cardiac event monitoring, I would be sure to select, I think there's 2 options. You can select MCOT or event. I would be sure to select the MCOT. That will give you your burden or amount. I don't believe the event will give you a breakdown of burden. So to be safe, you can order a Holter that will always give you a burden or amount, especially when you're working up PVCs. First line of treatment to reduce the burden of PVCs, beta blockers, the two most common that we use in our clinic are metoprolol, or can use carvedilol. If patients don't tolerate beta blockers, you can consider a calcium channel blocker, and diltiazem is the one that we use. And then, of course, if you're having a high burden, 10% or more, I'd say go ahead and refer them on, because there are further treatments for PVCs that can involve antiarrhythmic medications and even a PVC ablation if the burden is high and they're symptomatic, and especially if there's a cardiomyopathy associating. We do get pretty aggressive with treatment for these PVCs to either to correct or prevent a PVC cardiomyopathy. Here's an example of a common PVC. This is a left ventricular outflow tract PVC. So I've just put this in here as an example. With a patient, this actually appears to be by trigeminy with a PVC occurring every third beat. And I would say if you saw a patient that with a surface EKG with this many PVCs, I would definitely put a monitor on and probably order an echo to work these up. This is another example of another common PVC. This is the right ventricular outflow tract PVC. And you you do not have to know the origin of these, just knowing that when you looking at it, it has this wider QRS, and there is typically a little small pause that follows a PVC beat as well. Okay, so now I'm switching gears into atrial arrhythmias. And these, I listed the 4 common ones. That's SVT, ATAC, AFib, A-flutter that you likely will see in your practice. Actually, a lot of you guys are on the front line, and a lot of incidental findings of AFib flutter come through your clinic. And y'all have done a fantastic job getting those patients over into the cardiology EP world for treatment and management of these rhythms. I'll briefly touch on the AFib flutter. I know my boss, Dr. Elmbogen's giving a really excellent talk next month. He'll go into much more detail about those. But I just want to kind of give you the overview of these rhythms. So starting with SVT, common atrial arrhythmia. It's defined by having a regular, narrow QRS complex. Typically, your heart rate or ventricular rate is anywhere between 120 to 220 beats. What's causing it? You have this re-entry circuit and within the AV node, which is causing this short circuits, rapid. Very commonly, your patients will present saying they're having rapid, abrupt onset and offset, these rapid palpitations. Sometimes we can see these associate with lightheadedness, shortness of breath, and severe cases, syncope. More common in women, more likely in young adults, most cases beginning after age 20. Usually they develop in the hearts that are otherwise normal. So, you get an echo, structurally everything looks good. If your patient's telling you, I bear it down or I drank some cold water and it went away, that's a vagal maneuver. And if the rhythm terminated with it, I definitely would think SVT. So say you have a patient in your clinic, you get a surface EKG, and I will show you an example in the next slide. Actually, maybe I can. Okay, so you have a patient that comes in, and you get this on surface EKG. I would definitely go ahead and send on to the ER because very commonly the SVT it's fast. It can race. Patients typically don't feel well. And if it's certainly sustained, they either get adenosine or cardioversion. On the flip side, if you have a patient who has, pretty infrequent episodes or, some infrequent palpitations, you put a monitor on them, the monitor comes back and says they had 10 events with a 5 to 10 beat run of SVT. We would consider those short, very short. and really incredibly difficult to do any procedure for, especially when they're that quick, that short. So for most patients, if you're finding some short episodes, if they're pretty infrequent and well tolerated, most, they may be appropriate for conservative management. Um, if they do have some short, non-sustained beats yet are really symptomatic with them, you can certainly consider beta blockers such as metoprolol. For those patients that are having episodes of SVT, if they're frequently occurring, sustained, poorly tolerated, or definitely any event that results in going to the ED or requires adenosine or cardioversion, we recommend a catheter ablation as treatment, and I would go ahead and refer those on to EP. And also, screen patients again for any triggering factors, caffeine, alcohol, stimulants, they can be triggers. Okay, so now we're going into our next atrial arrhythmia, this being called atrial tachycardia. So this is by definition, a regular atrial rhythm at a constant rate of greater than 100 beats per minute, and it's originating outside of the sinoatrial node. Usually they're paroxysmal, self-limited. Most patients with atrial tachycardia report feeling palpitations, which is why I've included this. And this can be a challenging rhythm to identify. It's one that definitely keeps me on my toes and my clinic. If I'm seeing a patient who's having a heart rate above 100 beats, I'm definitely keeping extra caution to make sure I'm not missing this, because it can often be mistaken for, for a sinus tach, sometimes for, for SVT, depending on the rate. The characteristic thing to look at is the P wave morphology. So it may be normal, it may be abnormal, it might be positive, negative, biphasic. You could have focal ATAC that comes from one single site. You could have multifocal ATAC coming from multiple sites. And that difference is, subtle. You look at the P wave, there's usually a subtle difference from a normal sinus P wave, normal sinus beat compared to an atrial tach when someone's an atrial tach. So I usually, take the 1 EKG if I'm questioning it, and I compare it to a prior EKG and looking at the P wave. Patients that have rare brief atrial tachycardia episodes with few or no symptoms can be appropriate for as-needed treatment. For patients that have frequent symptomatic ATAC, you certainly can consider, again, medications with beta blockers, diltiazem, to help control the heart rate. And certainly in some cases, these patients do have further treatment with antiarrhythmic medication and/or ablation. Touching on AFib, this is by definition an irregular rhythm. Again, Dr. Ellenbogen will cover all of this next month, but I just want to give a nice, quick little review. You can identify AFib typically, with the heart rate. So you might have some patients that come into your clinic and rapid AFib, their heart rate may be up to the 150s. You may have a patient you're just establishing with as a new patient. You do your exam, you notice something's not right, there's irregularity to the pulse. You're listening to their heart, it's irregular. So you get a surface EKG and they're in AFib, heart rate in the 70s. And they had no knowledge, they were unaware of it. This is a very common thing we see, and it's an incidental finding of the AFib. And so rate can be variable, but the characteristic finding is that, it's irregular on surface EKG. There's no distinct P waves. As far as the classification, you can have paroxysmal AFib, going in and out of it, persistent AFib, where you're in it all the time, and then long-standing permanent. And I mean, those are, patients that have been in it for years. And as I said, kind of at the bottom of my slide here, earlier treatment of AFib definitely leads to better success in the long term. The longer a patient is in it, definitely the more difficult it can be. But what you want to look for, as far as with AFib, commonly in patients with structural heart disease, diabetes, hypertension, obesity, sleep apnea, is definitely one we've identified as well, and then heart failure. Reversible causes certainly should be assessed, looking at thyroid, asking about any alcohol, drug use, that can be precipitant for atrial fib. Screening for stroke risk is important too. You do that by calculating the CHADS FAST. Ways to work up, start with workup, obtaining an echo, looking at the size of their left atria. Very commonly, the longer somebody is in AFib, the more that left atrium stretches. You also want to look out for 5V dysfunction or systolic heart failure. That's, some patients may develop that with AFib. And so very important to screen for. You also want to look out for any valvular issues, if they have any issues with their mitral valve, aortic valve. Those are something important that's important to screen for. If you're seeing a really young patient come in with AFib, it's not as common, but we certainly are seeing it these days. And even more now so with patients that have Apple Watch monitoring, Cardia monitoring, it's being captured a lot more. So, but if you have a really young patient, definitely look out for any, try to screen for any reversible causes, if there are any. Some patients, especially if younger, sometimes when I've screened them, they didn't have any reversibility or reversible causes. And then I dive into their family history, and mom, dad, and brother and grandfather have all had AFib. So it definitely can run in the family. Rhythm control, that's the preferred approach to manage AFib. This can include cardioversion, antiarrhythmics, and/or catheter ablation. And then rate control is best used with metoprolol or diltiazem. And then that leads us into atrial flutter. We characterize this arrhythmia by a rapid, regular atrial depolarization. Typically, the ventricular rate is around 150 beats a minute. In patients, common symptoms certainly are palpitations, feeling short of breath, fatigue, lightheaded. I would refer to EP for management of this. Usually involves catheter ablation, which, atrial flutter, especially typical flutter, responds very well to that intervention. Can provide treatment in your clinic. Beta blockers help to control the rate. A flutter, like AFib, also should be anticoagulated to reduce risk of stroke. And commonly in my practice, I do see these both. I'll see AFib and then a flutter in the same patient. So definitely, certainly can run together often. All right. I put this in here. It's not common, but it might be something you come across in your practice. And I just wanted to highlight it just to help you identify. This is called WPW, or Wolff-Parkinson-White. The classic characteristic features are a short PR interval followed by this slur called the delta wave. And so if you see on surface EKG anything, a rhythm or that looks like this, that has that short PR and this slur going into the QRS, I would definitely refer them on. Commonly, what can cause this? It's an additional pathway called an accessory pathway. It directly connects the atria to the ventricles, and thereby allowing the electrical activity to bypass the AV node. So very commonly, the symptoms that we see patients might present with are palpitations and syncope, with syncope or pre-syncope, but palpitations alone could be sometimes a presenting symptom. And so definitely, check EKG to screen for that. One of the more common arrhythmias that associate with WPW is a type of SVT called AVRT. It's atrioventricular reentry tachycardia. And that, again, for treatment of this involves ablation of that accessory pathway. So I would just refer on if you do see this on surface EKG. All right, so I did throw in a couple slides here at the end. Something that I'm sure you'll see in your practice, we see in our practice, it's inappropriate sinus tachycardia and POTS and dysautonomia. To touch on inappropriate sinus tach, this occurs in individuals without any apparent heart disease or other cause for the sinus tach, typically defined by a resting heart rate of above 100 beats per minute, with a mean heart rate greater than 90 beats per minute over 24 hours. Usually patients have highly symptomatic palpitations or tachycardia as their presentation. And we typically, involve this as considered a diagnosis of exclusion. Initial management can include beta blockers, calcium channel blockers. I do find these are generally poorly tolerated, especially in younger patients, typically due to hypotension. If they do not tolerate that therapy, and in some cases we've utilized ivabradine as a form of treatment, but it's certainly something I've come across before in my practice. You may find it in yours. And really, I guess the way I really screen for this is you really definitely want to exclude anything else that might be going on. But a lot of times, like patients tell me that they just randomly feel their heart jump up and go like be at 100 beats or so, or 90 or 100 beats or so. And then it might stay there for an extended time, or then it might eventually calm down. Usually it's more gradual. And so in some cases I have had to escalate to, they didn't tolerate beta blocker, calcium blocker. Eventually, we try ivabradine. Sometimes it helps, but it is a difficult one, as is POTS and dysautonomia. This is a common one I'm sure you guys will come across in your practice as well. It's predominantly in patients in the absence of structural heart disease. Sinus tachycardia is only one component of this. It's truly a disorder of that autonomic dysregulation. You have excessive fight or flight. Common symptoms presenting will be palpitations, fatigue, lightheaded, exercise intolerance. The heart rhythm consensus statement defines POTS as a heart rate rise of greater than or equal to 30 beats per minute in the absence of orthostatic hypotension. You can screen this by obtaining orthostatic vitals and with a heart rate in your office. Treatment largely focuses on filling the tank and hydrating. That's going to be step one. Then maintaining hydration, can achieve that with a salt or electrolyte beverage, and physical conditioning, usually with recumbent exercises. Starting low, going slow. Just we'll put this out here. It's a really tough one. It's not managed, by cardiology or EP. We certainly can help if there's a cardiac issue or an arrhythmia, but this really usually involves like a multidisciplinary approach. We do have an excellent autonomic clinic here. I've utilized neurology sometimes gets involved, PT, psychiatry, the physical medicine rehab clinic has been substantial in helping with this patient population. But I just want to include it in there because I know, tachycardia, palpitations can be a big presenting factor with this condition. So when to refer? Any patients with a ventricular arrhythmia, any patients with structural heart disease, management of any complex atrial arrhythmias, patients who might benefit from a cardiac device, EP procedure, any antiarrhythmic medication, patients who have an all-around complex presentation, difficult to interpret EKG, or just unusual findings on a heart monitor. And I'm just going to put in a little quick case review for you guys just to test your knowledge here. So you have a 23-year-old female. She presents to your clinic. She's complaining of palpitations. She's telling you that they have this like quick onset, quick offset. They usually last minutes in duration. She's noticed these palpitations for the past few years, but they've progressively worsened. Associated symptoms include shortness of breath, feeling lightheaded, dizziness. What would be your next step? If someone wants to put it in the chat.
Looks like they put 4. Everyone's putting 4.
4 is correct. All the above. You would get an EKG, listen to the heart, feel the pulse. That's a good for initial H&P, physical exam, all of the above for sure. Okay, so my next slide here, you get the surface EKG. You listen to your heart, you've got this regular rate rhythm, S1, S2, no murmurs, remaining exam is normal. What would be your next step? 1, 2, 3, or 4?
Looks like everyone's putting number 1 down.
That's correct. I would go ahead and put a monitor on this patient, and what I want to look for is some sort of arrhythmia. Going to the next slide, cardiac monitor. Okay, so you put the monitor on. So whoever selected 1, that's the correct answer. Going to the next slide. Cardiac event monitoring results. You get a less than 1% PVC burden. Patient did trigger some symptoms of lightheaded, short of breath, heart racing, dizziness, all associated correlated with during sinus rhythm, sinus tach. You didn't capture any arrhythmias on this monitor. A couple weeks later, patient comes to ED, and you do see this EKG here. So putting in the chat, what is this rhythm? I did send an example earlier in the presentation.
Looks like people are putting in SVT.
That's correct. That's correct. Ding, ding, ding. So patient receives 6 milligrams of IV push adenosine. She has an improvement in her heart rate. Follow-up EKG so it shows signs of tachycardia, heart rate in the 100s. She started on metoprolol. What would be your next step or intervention for this patient? 1, 2, 3, or 4?
It looks like we got some 2 and a 4, some 2s and 4s.
Yeah, I mean, certainly both are reasonable. I would probably say for a young patient who has presented with SVT and has received adenosine, I would go ahead and refer this patient on to 2 EP so she can be considered for an EP study, SVT ablation for treatment. And definitely also observe for any recurrent episodes, but I would go ahead and refer her on to us. And that is the end of my talk. Happy to answer any questions that you guys may have.
Does anyone have any questions for Emily?
I do. Emily, thank you so much for this talk. It is so pertinent to primary care because I come across this like every day.
Of course.
One follow-up question I had, and you mentioned some in your slides, but with the structural heart disease component, sometimes if someone's getting an echocardiogram for some other reason and we see like sometimes some mild findings, is there any like findings that you are particularly looking for to maybe point you in the direction that this is something that could be stemming from some type of arrhythmia? Like, is there something you always look for, in the left atrium or the right atrium, or when you're kind of looking that could maybe cue you into maybe you're not capturing it, but something else could be going on?
Yeah, that's a great question, Sam. Definitely when I'm looking at the structure, I do focus on that left atria. And if it's saying in the report that this is moderately dilated or even severely dilated, next thing I look at, of course, is mitral valve. Is there any stenosis, regurgitation? I know blood pressure could have an impact too, but if I'm seeing like a stretch, really dilated left atria, my thoughts definitely do go to an atrial arrhythmia, and that being AFib. So I always do kind of, when I'm looking through my echo reports, I do go down to that left atrial size. Really big stretched LA or left atria would be, we consider that very severely enlarged if it's getting up to the 5 centimeter range. Certainly if it's in the 4.5, that's still considered enlarged. And I definitely keep my eyes open for any AFib if we haven't captured it. I'm looking for that. Other structural issues, of course, looking at the aortic valve. Is it stenotic? Is it regurgent? If that certainly is an issue, that prompts further intervention testing. And then looking at, LVH, thickness of the heart, that can sometimes prompt insight or looking into other causes, like any, cardiomyopathies that might cause arrhythmias. Hypertrophic cardiomyopathy, let's see, some other infiltrative cardiomyopathies could be amyloid and sarcoid. So if we're seeing this really thick heart, we're definitely keeping arrhythmias up in our differential too, because those can associate very commonly with those cardiomyopathies.
Awesome. Thank you so much.
Of course.
Emily, I know you touched on this a little bit, but you like the Holter monitors to be at least 1 to 2 weeks. And then when do you order them for that whole month? Because I mean, sometimes we see them for 1 or 2 days, and then sometimes we see them for a whole 30 days. Do you guys have kind of a guideline on
Yeah,
how long?
definitely. Yeah, Deb, great question. So for if I'm going into a 30-day MCOT, it's definitely usually screening if you're having a patient present with syncope. That would be a great reason for a 30-day monitor. If you're working up syncope, evaluating syncope, and just to give you that full 30-day duration to screen and look for any arrhythmias that may be contributing to the syncope. Other reasons I get a 30-day, if a patient has AFib, and I'm really trying to get a good assessment evaluation on the AFib burden, I'll typically do a 30-day. As far as, the 1 to 2 week, those are really great for giving you a burden on if you're working at PAC burden, PVC burden. If a patient's saying to you, I'm having some palpitations, they're pretty infrequent, but when they come on, they're pretty severe and they occur every 3 weeks, then that may prompt me to do a 30-day, so I can capture what may be going on, especially if they're more infrequent or drawn out, then I'll do a 30-day.
Any other questions?
Quick question for you, Emily. You mentioned, great talk, by the way. You mentioned using PRN medication for suppression of like those short runs of maybe ATAC or SVT. What's your go-to as a PRN?
My go-to, Delia, is metoprolol. I've seen the most success with that. Metoprolol tartrate, in helping with an episode. I've had patients have pretty good success, within 15 minutes of taking it to relax, calm down the heart and the heart rate. That's my go-to.
Do you usually use the 25 milligram
Oh,
tablet?
yes. Sorry. 25 milligram. So metoprolol tartrate, 25 milligram, 1 tablet, as needed at the onset of some symptomatic, episode, palpitations, tachycardia. Some patients have an established diagnosis. We've captured SVT, but they're very rare, very brief. I'll say and take 1 tablet at the start of a SVT. I'll usually write that in my as PRN as needed reason. If I have a patient who their pressure is a little soft, I might be a little conservative and say, hey, start with 12.5 to start, and then if it's not resolving, it's not improving, 15 minutes later, can take another half. I've done that before as well.
Thanks.
Any other questions? Well, thank you so much, Emily. This was a really engaging presentation, and I appreciate you showing us all those rhythms. That was a nice overview. As a reminder, text the code 34444 to 804-625-4041 in the next 48 hours. And then you'll have to complete your evaluation within the next 30 days at vcu.cloud-cme.com. Looking ahead at our next session will be Wednesday, August 20th at 5:30. As Emily mentioned, we're honored to welcome Dr. Ken Ellenbogen, who is the president of the Heart Rhythm Society, who will be presenting on atrial fibrillation and atrial flutter. So that's definitely a session that you guys do not want to miss. Thank you again for spending your evening with us. We're excited to see this series continue to grow across Virginia and beyond. Please share with your colleagues and let us know if you have any additional topics that you guys want to discuss. Again, my email is deborah.fora@vcuhealth.org. So I appreciate any feedback. Have a great evening, and we'll hopefully see you guys next month. Also, just a reminder that all of these sessions are on our YouTube channel. The YouTube channel is youtube.com/PauleyHeart, and you can see all of these series posted there. Thank you, everyone. Thank you, Emily.
Thank you, guys. Thanks for tuning in.